Hi, Mike Gibson, John Piccini coming to you live from AHA 2022, and we're talking about the safety and effectiveness of botulinum toxin to prevent AFib and kind of post-op bypass surgery patients. Talk to us a little bit about why you did this.
Yeah, so it's really interesting. We don't often focus on postoperative atrial fibrillation as it's a special case of atrial fibrillation, but it sure is a huge problem. It affects anywhere between 30 and 60% of patients undergoing cardiac surgery. And what's really interesting is despite all the innovation in cardiac surgery we've had, that incidence has been flat for decades. And there are available effective therapies, but some of the most effective ones have significant toxicities. Beta blockers are a class 1 indication I think everyone agrees with, but only 70% of patients in clinical practice get them, and many have them withdrawn postoperatively, which we know accentuates their risk. And then we also know that postoperative atrial fibrillation increases stroke, mortality, increases healthcare utilization. So there's an unmet need for a safe and effective therapy to prevent it. And we also know that the autonomic nervous system is really important in the initiation of many arrhythmias, including atrial fibrillation, and that parasympathetic stimulation shortens the atrial effective refractory period, increases dispersion of repolarization. We know that sympathetic stimulation increases automaticity and after depolarizations. And botulinum toxin, if you inject it into the epicardial fat pads, it impairs cholinergic transmission at the ganglionated plexi. And there actually have been prior studies that suggest that that may very well reduce atrial fibrillation. And so the hypothesis of the clinical trial is that epicardial application of botulinum toxin type A may very well reduce the incidence of postoperative atrial fibrillation after cardiac surgery.
Is the same Botox you get when you go to get your wrinkles, you know?
I probably should, right? Yeah. But no, I don't avail myself of that. But this is the same type of toxin that's used for those applications. So what we found, we randomized 323 patients in the 3 arms. So placebo, 25 units per fat pad, or 125 units total dose, or 50 units per fat pad, a total dose of 250. And what we saw in the overall population, which, by the way, was individuals in their 60s, 17% women, the vast majority who had isolated bypass surgery, but 12% had combination valve bypass surgery, and a quarter had isolated valve surgery. In that population, botulinum toxin type A at either dose did not reduce the primary endpoint of proportion of patients with an episode of AFib of 30 seconds or more. There were 2 strata, Mike. There was a strata for the presence or absence of valve surgery, and patients younger than 65 and those older than 65. Now, what's interesting is that we saw in the bypass patients, there was a trend to reduction of atrial fibrillation of about a third, and we saw the same thing in the patients 65 years of age and older. And what's interesting is other clinical trials that have targeted bypass patients only have found similar reductions.
And this isn't one of those things where, well, this subgroup went the right way, but, oh, that subgroup went the wrong way. It was the trend, the 30% trend over in those older bypass patients wasn't offset by harm over in the young valve patients.
No. So 2 important things you're bringing up. So what about safety? Because we're talking about injecting botulinum toxin into the heart. So what was very reassuring, consistent with prior studies, is that there were no differences in the adverse events or cardiac emergent treatment adverse effects. And there was actually a formal study of pulmonary function testing, because you might worry about impairing the diaphragm. No differences between that placebo.
So what's the next step?
Yeah, the next step is we need to learn more from the data. There are biomarker data from the study that suggest that the impact of botulinum toxin is not just from direct autonomic effects, but there was also a reduction in IL-6 and high-sensitive CRP. And that reduction occurred right around the time you would expect to see peak occurrence of atrial fibrillation after surgery. So we're trying to understand the data more, and then of course the dose. The last thing that I'll mention is that we saw something interesting. We didn't have any safety concerns based on prior smaller studies. So we assumed that the larger dose might be better. What we actually saw was that, if anything, the 125 unit dose appeared to be the most effective dose, which raises the question, can you suppress the parasympathetic nervous system too much to the point where you lose any potential anti-fibrillatory effect?
I see. Well, that's always the issue, right? It's this one is just right, the Goldilocks approach in dose finding, right?
Yes.
Good. John, thanks for joining us, and thanks to all of you for joining us here live from AHA 2022.